Hello, another video, this time talking to you about metabolic syndrome. The reason I'm doing this video has been prompted from a few headlines, a few people I've been talking to with regard severity of symptoms with COVID-19. And I want to show you how, for me, there's a link between some of the evidence that's coming out on COVID-19 and metabolic health of the population. And so this talk is all about trying to bring some of those ideas together and convey to you, not only that maybe there is a link between these conditions that seem to correlate with worse COVID-19 outcomes, but also there is a little bit of hope that actually this is something that we can manage. This is something that we can do something about. I have some slides to help me convey all of this, so let me get myself up and running on those slides. So let me start sharing that with you, and let's move to the beginning of the presentation, and off we go. So I'm going to talk to you about this thing called metabolic syndrome, something that many people probably haven't heard of, but I'm going to hopefully throw some light on that today for you. And as I mentioned in the little preamble there, what's prompted me to create this little video is in a response to some of these headlines we're seeing in the mainstream media, but also what I'm seeing in a lot of the scientific papers that are being published about COVID-19. And it's this looking at why do some patients get very severe symptoms from COVID-19, and why do some patients, in fact, it would seem the vast majority of patients, not get severe symptoms. And by severe symptoms, we could include hospitalization, requiring ICU care, manual ventilation, and ultimately, of course, death. So what are we finding in the data? And some of these headlines are distilling some of that. We can see there's mention there of obesity, high blood pressure, hypertension, diabetes. They're all conditions which in these reports are suggesting, well, if you've got one or more of these conditions, you are increasingly likely to have a severe outcome of COVID-19. And as I've said to you earlier in this talk, I think these things are related because of this thing called metabolic syndrome. Well, let's try and give metabolic syndrome a bit of definition. And essentially, if we're looking for a textbook style definition, it's a set of disease risk factors that indicate if you have these risk factors or a certain number of these risk factors, it indicates you have an increased likelihood of having or developing certain chronic diseases. So it's a measure of a fundamental measure, if you like, of underlying health in an individual. Now, let's put some specifics onto that. If we're talking about metabolic syndrome, how do you know if you've got it? Well, if you've got access to laboratories and doing blood test work, there are 5 very specific criteria that we have. Actually, the first one isn't blood work. This one, as you'll see, is a measurement more than anything else. The first of the factors, of which you have to have 3 or more to show that you've got metabolic syndrome, is having abdominal, so tummy, or visceral, around the organs, obesity. And as a very simple measure of this to make it measurable for most people, in men that's a waist measurement above 40, and in women that's a waist measurement above 35. So that's, it's pretty severe obesity in men above 40 inches at the waist, but it's our first measure of whether you may or may not have metabolic syndrome. Are you obese? Is that obesity centered around the organs or around the tummy? So it's like the apple-shaped fatness rather than the pear-shaped fatness that we're looking for there. Now we get on to the tests, which are blood work type tests. The first of those is fasting glucose. And there are different units for this. I'm sticking with consistent units for the remaining tests. This is milligrams per deciliter of blood. So it's a number you would get. So if you had a fasting glucose blood test, i.e. you didn't eat overnight, then first thing the following morning, a sample of blood is drawn and they measure the glucose in that sample. If your glucose level in that is above 100 milligrams per deciliter, that's another one of these measures that would go into the pot to determine whether you've got metabolic syndrome. If your blood pressure measurements are consistently above 130 over 85, that is the third measure of whether you might have metabolic syndrome. Another one of the blood work type tests, triglycerides. Now, triglycerides are a certain type of fat, certain type of lipid that we can measure in your blood. And what's interesting actually is that the conventional medical system tends to get very upset about measuring cholesterol, total cholesterol in your blood. Now, that unfortunately has very little meaning in terms of a statement or an assessment of your metabolic risks, but triglycerides do. And if you have something called a full lipid panel, it is one of the numbers that we measured. And if your triglyceride level is above 150 milligrams per deciliter, that is the 4th one of our factors that might indicate you have metabolic syndrome. And the fifth one is if you have very low levels or relatively low levels of high density lipoproteins, HDLs, which in the vernacular is often called your good cholesterol. There's certain issues with calling it that. Maybe I'll address that in another talk. But essentially, if you're measured HDL, again, it's another blood test. If you have the appropriate blood test, and again, it's part of the same lipid panel. If you had your triglycerides measured in a general lipid panel, so too would have measured your HDL levels. If they are below 40 milligrams per deciliter in men and below 50 milligrams per deciliter in women, that would be your fifth risk factor. So if you've had an assessment, so two of those are measurements you could do with a sphygmomanometer for the blood pressure, with a tape measure for your waist measurement. The other three are blood work type tests. If you've got three or more of those things true, then you would definitely have what we call metabolic syndrome. But there's something I want to sort of say, well, okay, if you've got metabolic syndrome, what are the consequences of that? Well, the biochemistry, the studies that are looking at the consequences of having metabolic syndrome show that it is hugely correlated with a wide range of conditions that we know about, conditions which are very prominent in the population. I'm listing many of them here, and I should briefly go through this list. So I'm going to start top left with type 2 diabetes. So type 2 diabetes is very strongly correlated with metabolic syndrome. So if you have metabolic syndrome, you're very likely also have type 2 diabetes. Type 2 diabetes is where you're not able to control your blood sugar levels effectively, and that has consequences, some of which I'll talk about later in this talk. Cardiovascular disease, CVD, so heart attacks, that sort of thing. Cerebrovascular disease, so the risk of stroke, CBVD. Polycystic ovarian syndrome, PCOS, and erectile dysfunction, they're related to metabolic syndrome. If you have issues with gallstones, gallstone disease. GERD, GERD, which basically reflux, acid reflux. Various forms of cancer, osteoarthritis, an inflammatory condition, many inflammatory conditions, in fact, but osteoarthritis is one of the most common inflammatory conditions. Neurological disorders such as Alzheimer's and dementia. Gout as a very specific but a very common one related to metabolic syndrome. A more vague but nonetheless an important sort of additional consequence of metabolic syndrome is fatigue, poor energy levels, poor focus, poor mental focus. A lot of evidence showing it's related to schizophrenia. Autism, development of autism could be related to metabolic syndrome. NAFL, non-alcoholic fatty liver disease, quite an increasingly common condition in the population. And I put it last, but in a sense that, and there's a reason why I put it last, obesity. Now, obesity is one of the big ones that is correlated with metabolic syndrome. So why have I put it last? Well, in a sense, metabolic syndrome is shifting an emphasis here, because we used to think, and many clinicians still do believe this, that actually obesity is the thing that causes many of the things on this table here. But actually, in the era of metabolic syndrome, it changes that slightly. It says actually metabolic syndrome is the main cause of all these conditions, of which one consequence is obesity. So effectively, obesity is a confounded variable with these other conditions, in the sense that if you do have obesity, it doesn't actually cause these other conditions. It's just that it's another marker to show that you have this underlying condition called metabolic syndrome. Now, remember on the previous slide, I said to you, well, if you've got 3 of those 5 measures on your list, you've got metabolic syndrome. But of course, that means you've got to have had the appropriate blood works done. It means you've got to have a blood pressure meter to have measured your blood pressure and so on. There's a sort of more observational, if you like, route of assessing metabolic syndrome. Do you have multiple conditions on this list? So if you're obese, you've got type 2 diabetes, you've got gout, you've got acid reflux. As soon as you start doing that, you think, oh, okay, there's a common pattern here. You've probably got metabolic syndrome. And the point I'm making there is that each of these 15 conditions I've listed here, they could have multiple causes. There are potential, or there's the multiple potential causes of each of these diseases. So cardiovascular disease might have a high genetic component. It might be hereditary in your family. What I'm saying is, if you've got a number of conditions in this list, actually what it's beginning to point to is that there's a common cause, and that cause is metabolic syndrome. So although you might not have the blood works to get your 3 out of the 5 lists from the previous slide, if you're showing you've got multiple of the conditions in this list here, then actually that would begin to start thinking, okay, maybe you've got metabolic syndrome. So that's metabolic syndrome. What I'm going to talk to you now is actually underlying that root cause is the fact that metabolic syndrome really is a measure of the fact that your insulin biochemistry is not working properly. So for metabolic syndrome, I'm going to introduce this idea. Actually, it's a syndrome of insulin dysfunction. So let's talk about this a little bit. Let me take a few examples from the list there. Let's talk about hypertension. So you remember that was one of the things, it was one of the original 5. In the 5 of the checklist, if your blood pressure was above 130/85, then that's one of your indicators. You've got metabolic syndrome. Now, why is that related to insulin? Well, insulin is quite interesting because insulin controls many things. Originally, the original observation with regard to insulin was that it's the key hormone we use to measure, to control rather, blood sugar levels. So if you've eaten a meal, and in that meal there are carbohydrates which are broken down to glucose, and that glucose gets absorbed into your blood. To stop the blood glucose levels remaining too high, the body releases insulin, and the insulin does something about that glucose. It moves it out of the blood, finds useful places for it. So it replaces energy reserves in the liver, for example. It creates this thing called glycogen, which is a form of storage of sugar for the liver. And it does similar things for the brain and the muscles as well. And then in any extra sugar left over, the insulin says to the body, okay, we'll go and store that as fat around the organs and under the skin. So insulin is a key hormone that controls excess sugar and what to do with that excess sugar. But insulin does so much more. And the example of why that affects hypertension, insulin, depending where it is in the body and which cells are responding to insulin, insulin causes the release of certain factors in the body which cause a number of effects, or have a number of effects, that bring about an increase of blood pressure. So some of these factors that are released in response to insulin cause vasoconstrictions. That's basically the narrowing of blood vessels. And also there are factors, or insulin causes responses that lead to the kidneys pumping or retrieving a lot more sodium, or putting sodium back into the body. Now, sodium is a salt. What that does, it increases the volume of blood. So you imagine you've got insulin, it's caused vasoconstriction, it's caused narrowing of the blood vessels, and also because of its effect on the kidneys, it's caused the volume of blood to increase. You've got more blood going through narrow blood vessels, you've got high blood pressure. It's increased the pressure. So the effects of insulin are, or one of the effects of insulin is, it will give you raised blood pressure. So if you've got a lot of insulin in your body, you will have a prolonged raising of your blood pressure as a consequence. A very specific one, polycystic ovarian syndrome. Again, insulin, one of the effects of insulin, it causes release of things called androgens. And if you've got sustained high levels of androgens, it affects ovary function. So you get an increased likelihood of developing this polycystic ovarian syndrome. Cardiovascular disease is an interesting one. Cardiovascular disease. So if you've got a lot of insulin in your blood, if you've got insulin in your blood, high levels of insulin in your blood, that then causes an inflammatory response in the narrow, very fine layer of cells, the endothelium lining the artery walls. That then sets up a chain of events. So cells of our immune system get drawn into the walls of the arteries through this thin layer of cells on the wall of the artery. They get drawn into the artery wall. They start then absorbing part of the cholesterol system we have, low density lipoproteins. It absorbs some of those, so that those primary white blood cells, or primary cells of the immune response, can do their job to manage the inflammation of the artery wall. And as part of that, they produce things called foam cells. Problem is, if you have too much insulin in your blood for too long, you start producing too many foam cells, and they then start forming the plaques that appear on the inside of artery walls, which potentially then become the cause of cardiovascular outcomes, like a heart attack, and so on. So the breaking off of those plaques. So the chain of that event started with insulin causing inflammation on the artery cell wall. It wasn't the fat, it wasn't the cholesterol, it was the inflammation caused by insulin on the endothelium, the lining of the artery wall. So insulin in prolonged high levels in the blood is a major contributory to cardiovascular disease. And the last one I'm going to choose as an example here, type 2 diabetes. Well, type 2 diabetes is where insulin, as I mentioned before, is the hormone that is there to reduce, when you've got excess glucose in your blood. It's the hormone there to bring those glucose levels down. We don't like glucose. We shouldn't have high levels of glucose in the blood, because that then starts causing problems for proteins in particular. So we have to have this mechanism, so when we get excess glucose, to bring the glucose levels down. In type 2 diabetes, what's happened is that the message, the insulin message that should be getting to the key areas of the body to say, let's start doing things with this glucose, let's get it out of the blood, those tissues start becoming deaf to the message. And so we start producing more insulin to get the message across, and we get caught in a vicious cycle of the body then gets more deaf to the insulin message. So you have to produce a bit more insulin to get the message across. And eventually your body cannot produce enough insulin to get the sufficient message across to start sorting out the blood glucose level. And that is really what type 2 diabetes is. There is insulin, there's lots of insulin in the body. It's just not enough to get the message across because the body's got resistance to the insulin message. So there's some good examples of how insulin is involved in hypertension, polycystic ovarian syndrome, cardiovascular disease, and ultimately is the cause of type 2 diabetes, or raised prolonged levels of insulin in the body, causes of those conditions. And so essentially metabolic syndrome, to give it in a sense a more useful name, it's actually insulin resistant syndrome. Just as I talked about when I was talking about this sequence of events that leads to type 2 diabetes, one critical thing within that sequence is that the cells that should be listening to the insulin message become deaf to the insulin message. They've been receiving the insulin message too much, too often, and they start becoming slightly desensitized to the message. That's insulin resistance. And in order to overcome the insulin resistance, the fact they've become deaf to the message, we have to start producing more insulin to get the message across. And that causes this spiral event that is part of insulin resistance. It's that insulin resistance that really is the nub of the metabolic syndrome. And essentially the reason that is a white Lisa metabolic syndrome is because of insulin resistance. The body's pumping out far more insulin than it should to get the key message across about reducing blood glucose. But because insulin does all those other things, when I talk about hypertension and the vasoconstriction and retrieving sodium in the kidneys, when we're talking about producing androgens, which affected polycystic ovarian syndrome, when we're talking about inflammation of the arterial wall, which led to that chain events, which led to a plaque. That's because we've got too much insulin in the body for too long. All of those responses should happen a little bit in the body, because we should only have a little bit of insulin going around. But we've got sustained high levels of insulin. All those adverse consequences, those consequences become adverse consequences because they're happening too much. So for metabolic syndrome, read insulin resistance syndrome. They're effectively the same thing. And I think insulin resistance syndrome is a more descriptive title for it because it identifies the key cause, insulin resistance. So let's just summarize a little bit of what I've just said. We start with glucose. Now, glucose is the form of sugar we absorb. So if you eat a food that's high in sugar or high in carbohydrates, the body will break it down. If they're digestible carbohydrates, break that food down into glucose molecules. Those glucose molecules become absorbed into your blood. That raises your blood glucose level. Because we don't want the blood glucose level raised, we're going to start producing insulin. That's a perfectly normal response, something we should do. When we eat our sugar, insulin kicks in, manages the sugar level, great. The problem is so many people now eat so much sugar in so many forms all the time, we're producing constant high levels of insulin to keep dealing with it. And as I mentioned to you before, if we keep doing that, the insulin message starts being lost. So we have to start producing more insulin to get the same message across. And that's a vicious spiral that leads us to this thing called insulin resistance. Now, insulin resistance over a long period of time, and again, I sort of alluded to this when I was discussing it on the previous slide. I'm going to give it its proper clinical name, leads to something called compensatory hyperinsulinemia. It's a very difficult word to say. I've been practicing and I still can't say it. Compensatory hyperinsulinemia. And what that means is compensatory, exactly what it says, compensatory. In response to that, there's all this extra, because we've got this deaf insulin message, or we've got the body that is deaf to the insulin message. To compensate for that, we're having to produce extra insulin. So in the body, there is hyperinsulin. There is raised levels of insulin for sustained periods of time to compensate for the fact that the key areas of the body are resistant to the insulin message. And it's that compensatory hyperinsulinemia that is the problem that leads to metabolic syndrome. So let's put that into, there we go. So that compensatory hyperinsulinemia is the key cause, the key component of metabolic syndrome. Now, in this previous slide where I introduced the jigsaw pieces, there was a critical point here. From insulin resistance, you develop insulin resistance, that leads to compensatory hyperinsulinemia. Let me just talk about other factors that cause that relationship, because they are going to be relevant to any discussion about how we can use this information in terms of improving the metabolic health of the population. In terms of whether you're likely to become insulin resistant in the first place, that seems to be very much determined by genes, hereditary. Some people are much more prone to insulin resistance than others, and a lot of that stems from your genetics. So your family history, whether there's a history of insulin resistance in your family or not, makes a big difference. But I like the analogy I read many years ago that in terms of the genetic disposition for conditions like this, genes load the gun, your lifestyle choices decide whether the gun is actually fired. So the fact that your genes might predispose you to insulin resistance doesn't necessarily mean you are going to become insulin resistant, because other things do affect it. Lifestyle choices, so by that, for example, exercise choices. Exercise, we know certain forms of exercise are very good at managing insulin resistance. The HIITs, the high intensity interval training, that's a very good way of managing insulin resistance, and good evidence suggesting that helps. So lifestyle choices, whether you drink much alcohol, whether there's much stress in your life, they can all make big differences. So DNA loaded the gun, but lifestyle choices, other sort of thing, will actually decide, will the gun actually be fired? And although it is part of lifestyle, but I want to separate it out as a particular, certain dietary choices do seem to make the big difference. Obviously, glucose is going to make a big difference, but I'll talk about that. But other things, for example, seed oils, artificial seed oils and margarines in your diet, they could have a huge impact in making you more likely to be insulin resistant. I might save that for another presentation, but essentially let's just raise the flag here. Your history, your genetic history, your lifestyle and your dietary choices all are contributory to whether you develop insulin resistance. But then if you've got insulin resistance, does that actually end up being compensatory hyperinsulinemia? Well, actually, the critical thing is sugars and carbohydrates in your diet, because you could be insulin resistant, but manage it very well by avoiding carbohydrates or minimizing the carbohydrates in your diet. It's only if you eat carbohydrate that your body starts pouring insulin into your blood. So even if you're insulin resistant, if you don't give your body carbohydrates, or carbohydrates in other than very low quantities, your body will not be required to produce lots of insulin to deal with it. I think I might have said that's a double negative. So let me try and say it the other way around. If you are insulin resistant and you eat a lot of carbohydrate, then you are going to get yourself into compensatory hyperinsulinemia. So dietary choices probably made a difference to your journey to becoming insulin resistant. But when you are insulin resistant, dietary will definitely make the choice whether you just sit in insulin resistant but managed, or whether it actually becomes the compensatory hyperinsulinemia. And that's really quite key, because if we want to reduce that, we've got to tackle ultimately the high carb diet. So take the high carb diet out, but also take out some of the lifestyle choices. So reduce stress in your life, become better at exercise, and other dietary choices. Improve all of those, we can probably reduce the compensatory insulinemia. And bringing this back full circle to where I started, because obesity, hypertension, high blood pressure, and diabetes are three of the co-morbidities. That's the word that's being used a lot now. These are the metabolic conditions that they tending to find are very prevalent in patients that have a poor COVID-19 response, because they are so prevalent, and because through this little talk I've shown you they're related to the consequences of insulin resistance. If you can start taking the trigger for compensatory hyperinsulinemia out of your diet, you can start reducing your diabetic response, your hypertensive response, and even, well, I say even, but critically, and it's one of the biggest observables when you start taking carbohydrates out of your diet, your levels of obesity, if you're overweight or obese, your body weight will come down. So you're tackling very specifically the comorbidities that seem to be correlated with poor COVID-19 outcomes. So there we go. That's my discussion of metabolic syndrome and why it might be relevant to So there's me taking the carb diet and reducing the compensatory high levels of insulin in the blood. So just a little bit provocatively, a little bit controversially, shall we say, I'm going to finish this talk by taking the meme that obviously has been very much part of our lives for the last 4 weeks of lockdown, stay at home, protect the NHS, save lives. Well, maybe there's another one. Maybe there's one which actually eat healthily. If you can eat healthily, if you can manage your metabolic syndrome, reduce your obesity, reduce your hypertension, reduce your level of diabetes. I mean, what's very interesting, low carbohydrates diets have been proven to reverse type 2 diabetes. Type 2 diabetes isn't a given for the rest of your life. If you develop it, you can do things to reverse the severity of the symptoms, and in many clinical cases, they've actually taken away any need for medical or pharmaceutical intervention with type 2 diabetics by managing the carb intake of those patients. So by making healthy eating choices, you can reduce your comorbidities that you present, which in its turn is going to reduce your likelihood of needing hospitalization in the current COVID crisis. There's my provocative thought at the end, but it's a thought that I just want it to become part of the discussion at this stage of what happens next in the COVID-19 situation. So there's my talk on metabolic syndrome. Thank you for your time. Hope that made sense. If you like this talk and would like to see more, just like, share, and follow me on my YouTube channel. And I will see you again soon. Thank you.